So I do think there may be a role in select patients, and we do use it at our center on occasion when we have nothing else that seems to work and the patient continues to have high elevated lactate levels and ongoing shock. But HAT therapy cannot be recommended as a routine therapy for septic shock based on the current level of evidence.
Welcome back to PScript. I'm Zach Hodges, a pediatric ICU fellow from UT Southwestern in Dallas.
And I'm Al Shanklin, a critical care fellow in Washington, D.C. Zach, who are we talking with today?
Today, we're excited to have Dr. Scott Weiss back with us on the podcast. Dr. Scott Weiss is the Division Chief of Pediatric Critical Care at Nemours Children's Hospital and an Associate Professor of Pediatrics and Pathology at Sidney Kimmel Medical College at Thomas Jefferson University. He also recently served as the co-vice chair for the International Pediatric Surviving Sepsis Campaign and was the first author on the 2020 Pediatric Sepsis Guidelines.
Yes. In part 2 of this 2-part series, we're talking about vasoactive agents and then the way that you really trend and respond to hemoglobin and lactate values throughout these patients' course. He also does talk about adjunct therapies, including metabolic resuscitation, and we are so grateful to have the chance to talk with him.
That's right. Such a great conversation. Answered so many of our burning questions about sepsis. Let's get right to the content. You have this patient. They're sick in front of you. They have evidence of ongoing shock. You need to do something. They've already got fluid resuscitated. You don't think additional fluid is going to help. Walk us through your mental model for how you choose your first vasoactive. And tell us specifically what that usually is and when might you choose a different agent.
Yeah, so for a long time, dopamine was the preferred first-line agent for children with septic shock. And that was primarily a practical selection because dopamine was easily available. In the not-so-distant past, it often had to be diluted at the bedside, reconcentrated at the bedside, and so dopamine was easy to do. And so for a lot of practical reasons, dopamine kind of became the first-line vasoactive. There were 2 trials that were conducted, one in India and one in South America in pediatric septic shock that actually showed head-to-head epinephrine had a mortality benefit as an initial vasoactive agent compared to dopamine. Now, there were some problems with that study in that the titration of epinephrine was probably more aggressive than the equivalent titration of dopamine. However, that also lends to the characteristics of the agent itself and how we dose those 2 medications. And so whether it's the agent itself or how it's titrated, I'm not sure it matters. But the initiation and titration of epinephrine had a mortality benefit in 2 trials. In addition, dopamine has a lot of off-target effects, including some adverse endocrine and immunological effects that make it perhaps not the best first-line agent. And then, of course, there's some adult trials that suggest that dopamine is more arrhythmogenic and more problematic compared with other catecholamines. And so the constellation of that data really evolved pediatric guidelines to now epinephrine really being the first-line favored agent. Epinephrine is also a more potent inotrope than dopamine, and so for the majority of kids who come in with some degree of myocardial dysfunction, epinephrine probably has some benefits. Now, there's no head-to-head comparisons of epinephrine versus norepinephrine in pediatric septic shock. Whether or not epinephrine is better or the same or worse than norepinephrine is not clear. And in fact, there are areas of the world that generally prefer norepinephrine as the first-line vasoactive therapy. And the Surviving Sepsis Campaign allows for either, really, epi or norepi as a first-line agent relative to dopamine. So what I would say is that if you have an undifferentiated septic shock patient and you have to pick an agent without additional data, epinephrine is a reasonable first-line agent, although norepinephrine would be an okay alternative as well. However, if you have the ability to gather some additional information, such as a point-of-care cardiac ultrasound, and you notice myocardial dysfunction, that might better support your use of epinephrine. Whereas if you notice hyperdynamic cardiac function and the patient does feel vasodilated on exam, then that combination of findings might move you towards starting norepinephrine as an initial first-line agent.
Zach knows that I work with a handful of people that either did residency at CHOP or work for a year at CHOP, and they're all really fabulous at point-of-care cardiac ultrasound. When do you know when to add a second pressor? Or how do you know when to add a second pressor?
Yeah, maybe I'll just change the terminology to vasoactive because not all vasoactives are meant to be pressors, right? So I'll say when your first vasoactive isn't working, you should think about a second. The question then becomes is when is your first vasoactive not working? It's not entirely clear what defines failure of your first vasoactive. But in general, if you start your first vasoactive, whatever it is, and you find yourself having to escalate frequently, you should at least think about whether or not an alternative agent might be useful. And so doing some of those additional monitoring things that we just talked about might be helpful to help you understand the patient's physiology, and maybe that might alter your approach a little bit. Everyone, I think, has slightly different threshold in terms of when they consider adding a second agent versus continual up titration of the first agent.
So say this septic patient's in your ICU, you started them on an epinephrine infusion. When might you reach for a second vasoactive?
My personal threshold to even think about a second vasoactive for either epinephrine or norepinephrine would be if I'm titrating above 0.1 micrograms per kilo per minute, I start to think about potentially adding a second agent. Now, that second agent selection can also be a challenge. There are some really nice data from adult septic shock that demonstrate that the addition of vasopressin can reduce the need for high catecholamines, specifically norepinephrine, which is the preferred agent in adult septic shock. Now, that doesn't necessarily improve outcomes, but it does reduce catecholamine dose, which in and of itself, high doses of catecholamines have some adverse side effects that one might want to avoid. So in general, adding vasopressin has become accepted to reduce the need for high-dose catecholamine dosing in adult septic shock. If you take that evidence and translate it to pediatrics, I think there's a reasonable role for that indirect evidence from adults to inform practice in pediatrics. Now, we don't have the same robustness of studies for vasopressin that adult sepsis has. However, there are a few small studies that suggest that vasopressin could be useful. The challenge is that the biggest study actually showed a trend towards increased mortality. So it's hard to sort of reconcile the potential physiologic benefits of vasopressin in pediatric septic shock with at least one study showing the potential for harm, and then most of the data that's showing benefit being indirect from adults. Mm-hmm. And that's why the Surviving Sepsis Campaign's recommendation is really to either use vasopressin as a second agent to limit catecholamine dosing or to further up-titrate catecholamines and avoid vasopressin. My personal choice is reflected on some of the augmented hemodynamic assessments of the child. So if the patient has robust myocardial function and appears warm, then I would be more inclined to add vasopressin to try to treat what I think is more of a vasoplegic picture. Whereas if the patient has ongoing myocardial dysfunction on POCUS, despite epinephrine, I stay away from increasing afterload with things like vasopressin. And in that patient, I would focus more on either additional volume or better ways to augment inotropy.
I think your practice certainly reflects what we do in Dallas as well. And I really am fascinated with vasopressin as an agent because I feel like its dosing is somewhat mysterious, where I hear there's going to be flat rate dosing that maybe is sometimes used in adults, but maybe not as often in pediatrics. And there's also effects on urinary water reabsorption. Theoretically can alter urine output. So a couple of quick follow-up questions. If you initiate vasopressin, do you typically use a flat dose or would you titrate it similar to your other vasoactives?
This is a difference between pediatric and adult septic shock. So the background for using vasopressin really stems from the fact that vasopressin serum levels, if you measure them, are generally low in sepsis. And so there seems to be, a quote-unquote vasopressin deficiency. And so giving vasopressin back exogenously seems like it might make sense. So adult sepsis practice has generally been to give vasopressin as a standard dose without titration. In pediatrics, the preference has generally been for a titratable dose. My own personal practice is to start at a dose of somewhere between 0.3 and 0.5 milliunits per kilo per minute, and then titrate up to response to a dose that's usually not higher than 2 milliunits per kilo per minute. Now, the follow-up question is, that translates to actually quite a high dose of vasopressin if you compare that to the doses we use for the more common indication for vasopressin, which is diabetes insipidus. right, where vasopressin tends to be dosed in millunits per kilo per hour. And so, a dose of 0.5 millunits per kilo per minute is equivalent of 30 millunits per kilo per hour. And so it's an awfully high dose. Most of the time shuts off someone's urine output in DI entirely. Interestingly, we don't see the same effects on water regulation in sepsis that we see in DI. And I don't think that's really well understood. To be honest, I've never come across a good explanation for why we don't see a reduction in urine output and iatrogenic hyponatremia when we use vasopressin in shock, even though the dose tends to be higher than we use it in DI. So it's a good question. And if anyone has an answer to that, I would be interested in hearing.
Oh, yeah. They can land themselves on the podcast for an episode on it, I think. So as maybe an end to this particular section, early in my training, I was taught that I should have checkpoints built into my resuscitation of sick patients. A good example would be a patient in severe respiratory failure who I have on BiPAP. Should I really increase the PIP to 30, or should I just bring the airway cart over and let's prepare to intubate? I feel like in sepsis, in the management of patients in septic shock, having that checkpoint of I'm starting a second vasoactive might be a helpful time to just take a step back, reconsider the patient in front of me, and you think, is this actually just pure sepsis, or is there something else going on that I haven't identified and captured yet, and no particular amount of, quote, sepsis treatment is actually going to affect this? When you have a patient like that, has ongoing shock, despite what you think of as good sepsis resuscitation measures, what are some common mimics of sepsis that we need to be careful to identify?
Yeah, it's a great point, Zach, and I think you're right on. I think if you're starting to increase beyond an equivalent of 0.1 microgram per kilo per minute of epi, you're escalating beyond that either by increasing the dose or reaching for a second agent. I think that's a good checkpoint to say, am I treating the right thing here? Or is all I'm treating septic shock, or is there something else going on? Because while that certainly is a phenotype that we see in septic shock, it is not the common one, right? It is thankfully rare. And so it's important to kind of have that mental check. I think one of the important mimickers in the current day and age would be MIS-C, multi-system inflammatory syndrome in children that follows COVID. That's probably one of the more common mimickers of sepsis and would be treated differently than septic shock. So that's an important one in the current era. Adrenal insufficiency, I think, is another one. Lots of children have absolute adrenal insufficiency from a variety of reasons, either because of underlying comorbid conditions or because of recent treatment with exogenous steroids. And so those patients do need steroid replacement. Electrolyte abnormalities like hypoglycemia and hypocalcemia, particularly in infants, can lead to refractory shock and should be addressed. Kawasaki disease, Kawasaki shock, while rare, is another common problem. Pancreatitis would be another one. So thinking about whether you have the right diagnosis is obviously important. And then there are some patients who, especially if they get massive fluid resuscitation, can develop an abdominal compartment syndrome. That should be addressed and can lead to a refractory shock state, as can other causes of shock, such as tamponade or pneumothorax, PE, and so on. So taking a step back and thinking through the patient holistically, I think is important. And I think the time to do that is when you're reaching towards a second agent or increasing above 0.1 of epi or norepi.
Oh, absolutely. There's truly nothing worse than an abdomen that's hard as a rock and surprising to you, right? Let's go back to our case and get an update. This is an 11-year-old with urosepsis. You've titrated her epi up to 0.1 mics per kilo per minute. Her blood pressure is now improved, but she continues to have poor peripheral perfusion. Labs include urinalysis that's consistent with infection, a leukocytosis of 25,000, and an anemia with a hemoglobin of 7.5. Her lactate remains elevated at 4. With this patient who has ongoing shock, her hemoglobin is 7.5. Would patients with ongoing shock like this benefit from a hemoglobin target higher than 7?
Yeah, it's a great question. And I think this is an important area that needs further investigation to truly answer that question with real evidence, because we just don't know at this point. Historically, going back to the late 1990s, early 2000s, really around the time that the Manny Rivers early goal-directed therapy trial was published that showed a mortality benefit for an early goal-directed therapy algorithm in adults with septic shock. That algorithm included maintaining a hemoglobin threshold of 10 or higher as part of your initial resuscitation efforts in the first 6 hours. And of course, that trial showed a mortality benefit for early goal-directed therapy algorithm. And so the hemoglobin threshold of 10 was quickly adopted as part of that. That hemoglobin threshold itself wasn't really tested as an independent part of the algorithm. From that data, we don't really know whether or not 10 is the magic number or not. In the follow-up trials, 20 years later, Process, Promise, and Arise, 3 concurrently performed randomized controlled trials in adult septic shock that compared early goal-directed therapy, as Manny Rivers described it in the early 2000s, to what had become more of a standardized usual care approach, which was like a watered-down, slightly less aggressive version of that algorithm. All 3 of those trials showed that you could achieve excellent outcomes with a less aggressive protocol. At least the PROMISE study algorithm for standardized care included a hemoglobin threshold of 7.5 rather than 10, and there was no difference in outcomes for the protocol arm that included a hemoglobin threshold of 10. There was also a trial in adult septic shock out of Scandinavia that compared a restrictive hemoglobin threshold of 7 versus 9, and again, no difference in outcomes for that study as well. And so there does seem to be newer data that suggests that not all patients require such a high hemoglobin threshold. The best data we have for children comes from the TRI-PICU study, which was published by a group in Canada that compared transfusion at a hemoglobin threshold of 7 versus 9 or 9.5 in children with septic shock who had obtained hemodynamic stability. And that was defined by either being off vasopressors or not having to increase vasopressors for 6 or so hours. And in that study, there was no difference in newer progressive mods for children who got randomized to a high versus low hemoglobin threshold. But that was for kids who had obtained stability. The knowledge gap we have is in the child, like you described here in our case, who's still in the throes of initial resuscitation and not responding to initial fluids and vasoactives and still having evidence of impaired perfusion. Do we then pull the trigger and target a higher hemoglobin threshold? The TAXI guidelines, which put out evidence-based guidelines for transfusion practices in children, and the Surviving Sepsis Campaign, which specifically focused on septic shock, both agree that no recommendation can be made as to a specific hemoglobin threshold for the early resuscitation of children with septic shock because we just don't have the data. My personal practice is that I don't target a specific hemoglobin threshold, but in a patient like this, in whom you've felt like gotten source control, you've given some fluid resuscitation and you don't think there's benefit to additional fluid, you've up-titrated your vasoactive support, you've ruled out other concurrent reasons that they might have shock, and they still are anemic below a hemoglobin of 9 or 9.5, especially if they have evidence of hyperlactatemia and a low SVO2 saturation, I would then transfuse with packed red blood cells as an alternative way to try to improve oxygen delivery to that child.
And I think that makes plenty of sense. If we've optimized everything else, we're not going to let a patient have ongoing shock with a hemoglobin that's around 7. So something that we've referenced a couple times is hyperlactatemia, how relevant it can be for our patients who are really sick with sepsis. And in our case, we talked about a patient with a venous lactate that was up around 8 and has slowly fallen from 6 and now only to 4, maybe in the first 6 to 8 hours of her resuscitation. So tell us, this patient who's on vasoactives, who's sick in front of us, what does this lactate of around 4, moderately elevated, maybe 8 hours into her clinical course tell you? And how do you interpret that in the context of her epinephrine infusion, which might be contributing to some, oxygen delivery independent type B lactic acidosis?
Sure. Yeah, so as you mentioned, epinephrine can drive aerobic glycolysis, which can increase lactate, not through anaerobic metabolism, but rather through increased production of pyruvate, which gets offloaded to lactate. So hyperlactatemia, when a child first presents, is most often related to impaired oxygen delivery and anaerobic metabolism. As time progresses, if the child continues to have a hyperlactatemia, the etiology for that elevated lactate can become more complicated. So we often worry, of course, about ongoing impaired oxygen delivery, and that may still be present. But mixed in as reasons for an elevated lactate might be medication effects like epinephrine, and there are other medications that actually can drive aerobic glycolysis as well. Any impairment in hepatic metabolism might reduce lactate clearance through impairments in the Cori cycle. And then you can also have direct impairments in mitochondrial function and in moving pyruvate through acetyl-CoA into the mitochondria as well. The interpretation of lactate, I think, becomes a little more difficult and needs to be done in the context of other assessments of the patient. So if you have a patient who has improving urine output, blood pressure looks good, heart rate has come down, mental status is improving, SVO2 is getting better, your POCUS reassessments are looking improved, and the lactate's still marginally elevated, I wouldn't necessarily chase the lactate in and of itself. Again, the Andrometer study I mentioned earlier suggested harm if you solely titrate your resuscitation exclusively to lactate reduction. However, if the lactate remains 4 and you still have evidence of impaired perfusion and your other assessments suggest that you're still in shock, then I would be more aggressive. So I think the fact that the lactate in this patient has come down from 6 to 4 is a good sign. The fact that it's still 4 is concerning, but cannot be interpreted, I think, in isolation in and of itself.
The theme of the conversation is look at the entire patient in front of you and use what tools that you have. And maybe a learning point also could be, this lactate of 4, we don't love it, but as long as we continue to see it improve, or at least see the patient in front of us improve, we should be reassured somewhat.
Yeah, I think that's right.
So there's been a lot of press, I think, over the past 5 years about the idea of metabolic resuscitation. Are we adding vitamin C? Are we adding thiamine? What do you think about this?
Yeah, it's a great question. And you're right. This is an area that has gotten a lot of attention, both in the scientific community as well as in the lay press. So the concept of metabolic resuscitation is one in which you're actually trying to target an improvement in enzymatic reactions that result in an overall biochemical profile that allows for increased oxygen production and other cellular functions to work more efficiently. Right? The fact that there is metabolic dysfunction that requires resuscitation, I think, is well encapsulated in the most recent Sepsis 3 definition of septic shock, which includes cellular metabolic dysfunction as a component of shock and moves us away from thinking about shock solely as a cardiovascular phenomenon. Conceptually, I think metabolic resuscitation is extremely important and probably is one of the key elements of the future of critical care medicine. The specific use of hydrocortisone ascorbic acid and thiamine as combination cocktail for metabolic resuscitation really stems from the fact that those things are low in patients who have critical illness and sepsis. So generally, those patients have lower levels of thiamine, lower levels of vitamin C, and some derangement in cortisol metabolism. Right, so all 3 of those agents have been tested both in combination as well as separately for improvements in septic shock. The excitement with using HAT therapy, which is hydrocortisone ascorbic acid and thiamine in combination, comes from a single center pre-post study that was published by Dr. Paul Marik, which showed showed a remarkable reduction in mortality in adults treated at his center, from about 40% to about 4% when they were given HAT therapy as part of their initial resuscitation. And why they chose to do that is a little beyond the scope, but I would encourage people to read that article in Chest. It's, I think, a good paper that did what it was supposed to do, right? It excited people about a new potential therapy and led to subsequent high-quality randomized controlled trials to test the hypothesis that was generated by this pre-post observational study, right? I think where people got in trouble is they started changing practice based solely on a study that didn't have the quality of evidence necessary to be practice changing. But in the years since that publication of that study, we now have about a dozen published trials looking at hydrocortisone ascorbic acid and thiamine in patients with septic shock, almost exclusively adult patients. And what we have learned is that there does not appear to be a consistent signal for benefit in using those 3 agents in combination. Now, there have been a few studies that have suggested some benefits. There's been a few studies that have suggested some harm. But when you look at the more recent meta-analyses for adults with septic shock, there does not appear to be a huge benefit signal, and certainly not a statistically significant one. If there was going to be a signal that was as robust as the one that Dr. Merrick described in his observational study, you would think that we would have seen it now. And so it certainly suggests that perhaps HAT therapy cannot be routinely recommended for patients with septic shock. Now, that said, these therapies in general are safe. There are some potential side effects. Ascorbic acid in particular can cause oxalate nephropathy and AKI and some hypernatremia. So those are things that need to be monitored for. Thiamine can be useful, I think, particularly in patients with persistent hyperlactatemia, because it can promote metabolism of pyruvate through enhanced mitochondrial function by acting as a cofactor for pyruvate dehydrogenase, or PDH. And steroids have their own controversies. So I do think there may be a role in select patients, and we do use it at our center on occasion when we have nothing else that seems to work and the patient continues to have high elevated lactate levels and ongoing shock, in particular when we're starting to think about movement towards VA ECMO. But HAT therapy cannot be recommended as a routine therapy for septic shock based on the current level of evidence.
That's really helpful to hear. And it's not something that I have any experience with. We certainly use hydrocortisone, but not as much thiamine and ascorbic acid for these septic patients. Do you know of many other programs who use this routinely in pediatrics?
So the only group in pediatric critical care that I'm aware that uses HAT therapy routinely is Lurie Children's. And this is primarily based on an observational study that comes out of that center that showed an association of lower mortality with HAT therapy compared to hydrocortisone alone or neither of the three therapies. That was a very nice study. It was attempted to be propensity controlled, but again, as with the Merrick study, is an observational study that does not rise to the level of the highest quality of evidence. So I think there needs to be some caution there. Now, with the barrage of randomized clinical trials that were published that did not show benefit in the last few years, I'm not sure if practice has become a little more subdued there, but in general, across the field, HAT therapy is not a standard therapy in pediatric septic shock management, nor should it be.
Regardless of HAT therapy use, I'm curious as to what triggers you to add hydrocort and what your personal practice is. And I'm also curious at what point really do you call for VA ECMO?
Yeah, so hydrocortisone therapy is interesting. People have been testing whether or not steroids are useful in septic shock for a long time. And just briefly, backstory is that high-dose steroids, particularly with methylprednisolone, were attempted as an anti-inflammatory therapy back in the late 1980s, early 1990s, and did not demonstrate benefit. In fact, there was some sense of harm. And then there was renewed enthusiasm in the early 2000s with using low-dose hydrocortisone as potentially a way to augment cardiovascular support, but not really focused on as an anti-inflammatory agent. And there was a French trial in adults that showed benefit when low-dose hydrocortisone was used in combination with fludrocortisone. That benefit was not supported in a larger multi-center international study called Corticus. And so the recommendations for use of hydrocortisone have kind of evolved. The more recent trials in adults continue to show controversy with a repeat French study showing benefit and a repeat multinational study, again, showing no mortality benefit, but perhaps people got better faster and left the ICU quicker. And so the current recommendations for both adults and children are to use, or at least consider hydrocortisone for patients with fluid refractory catecholamine-resistant shock. The Pediatric Sepsis Campaign qualified that a little bit in saying that, that's a reasonable option, but also not using hydrocortisone is also reasonable given we don't really have really high-quality pediatric evidence. Now, there is an ongoing trial in children called SHIPS that will hopefully provide some additional evidence about whether hydrocortisone is useful for refractory septic shock. My current practice is that if I'm escalating catecholamine agents beyond 0.1 micrograms per kilo per minute of epi or some equivalent agent, that I would reach for hydrocortisone as an adjuvant until such time that we have additional data that may show that that's not the right approach. Or if you have a patient who has adrenal insufficiency for any number of reasons, then I would start hydrocortisone as part of the initial resuscitative care for that patient. In terms of ECMO, the outcomes with use of VA ECMO to support children with septic shock suggest that it has an important role. Mortality is high, roughly around 50% if you look sort of across centers, but that's for a subpopulation of children with septic shock who have an extraordinarily high mortality even without ECMO. And so 50% mortality or 50% survival in that group is probably reasonable because many of those patients, if not all of them, would perhaps have died without ECMO support. And so there probably is a role there. Now, I don't think there'll ever be a randomized controlled trial of ECMO. And so we're left with really looking at observational data. The best data for pediatric septic shock really comes out of the Australian group out of Melbourne, which has shown some really good evidence that ECMO can have a really important role, particularly if you can achieve high output flows above 150 mLs per kilo per minute. You can really tend to have pretty good outcomes in those patients. But only about 1 to 2% of children who find their way into an ICU will end up being cannulated for ECMO. It becomes really difficult to say exactly when one should use ECMO. The European Society of Pediatric and Neonatal Intensive Care tried to get at this with a paper that was published about 5 years ago, where they showed that children who have a refractory septic shock as indicated by a vasoactive inotrope score of greater than 200, a lactate level of 8 or higher, and LV dysfunction or cardiac arrest may benefit from cannulation at ECMO because their mortality is so high. But again, the criteria that one uses to go on VA ECMO is not really evidence-based. My own personal practice is that when you find yourself escalating catecholamines to very high doses, probably also on vasopressin at that point, and steroids, and you're not showing any improvement over the course of several hours, that you really need to start thinking about whether transition to VA ECMO is the right thing to do. The other group of patients who I think would benefit from ECMO are those patients who are peri-arrest or who you're doing CPR. There is evidence that eCPR with ECMO rescue can be helpful in patients who have a cardiac arrest with septic shock.
So great. This has been an exceptional conversation, a wealth of knowledge here, something that I wish I had access to 18 months ago when I started this critical care fellowship. Dr. Scott Weiss, we really appreciate your time, sharing your knowledge with us and our listeners. And I really feel like this is going to be a durable resource for years to come. As we move towards the end of our conversation, is there anything else that you'd like to share with us or our listeners before we wrap things up?
No, I just thank you for the opportunity to come talk a little bit about the management of kids with sepsis and, interject some of the recommendations from the Surviving Sepsis Campaign. Is evident from our conversation, there's still a lot we don't know. There's still a lot of opportunity to improve the way we care for children with septic shock, especially those who end up in the ICU and don't improve quickly with just infection source control, fluids, and supportive care. So encourage people to question what we're doing and why we're doing it. And when they can't find relevant answers, that should be the thing that drives them to go into science and help us understand how to take care of these patients better.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review on your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.